up there, Greg. Okay. Pressure's good, ECG is stable. There's not much wire beyond it, but okay. So we're ready to go now, Raghu. I want 10 volts output, 180 pacing on, please. 180. Bit of hush in the room, thanks. Pressure's coming down, and up we go, John. Nice and gently does it. And pacing off, thank you.
Now the first thing to do is to check on the valve morphology, to check the valve mobility, just see if there's any aortic regurgitation, which is what I'm doing right now. No, it seems fine. No AR. So what we'll do is just review that sequence now. You can see here we're inflating with a 20mm balloon, and that seems fine. There's enough space in the sinuses for those valve leaflets, bearing in mind that we're going to need to allow about another 1 to 2mm either side, because that's the balloon will be inflating to another 3mm in diameter. The valve will be, sorry, when it's deployed.
Okay, Raf, you manage the wire.
Okay, so what we're going to do now is get ourselves ready to look at the position of the valve, and I like to do this in a live 3D mode because that gives me the optimum compromise between spatial and temporal resolution. So I'm just adjusting this now so we have the valve in the middle of the image, and then I want to make sure that the gain is not too high so we can see the valve properly, see the texture of the valve crimped onto the balloon. And also we want to look into it. So if you notice as I rotate this round here, I'm just slightly off the edge here, not going right down to the center of the aortic root, so that we can see, there we go, so we can see right into the valve. And then we'll bring this back here and center it up a little bit. Now I'm just going to rotate that round a little bit more and get it laterally positioned correctly. Yeah. So now it's all being positioned across the valve, and they're actually preparing the valve in the descending aorta at the moment. Now from an echo point of view, what we want to try and achieve is that the bottom of the valve is situated at the base of the anterior mitral valve leaflets, and the top of it is going to cover the native valve leaflets you can see there. Now you can see it being advanced across the valve. We can actually see the crimped sapien valve clearly sitting there. There's the top of it, here's the bottom of it, just here. And so we've got to remember this valve is going to get a bit shorter during deployment. I'm moving the probe all the time, I'm scanning backwards and forwards across the valve plane. This is where we want the bottom of it lined up, and the top of it to cover these native valve leaflets that you can see here. So there's the top of the sapien.
Far off. How's that looking with you, Mark?
It looks actually perfect position. I can see that it's covering the top of the native valve leaflets, and the LV side of it is at the base of the anterior mitral valve leaflet. So from my point of view, that's a good position.
Can I see the pigtail? Just show me the pigtail. It's just caught, it's doubled up.
Disengage, come back and reapproach.
Follow that. That's better.
Perfect.
Mag up. Great, thank you very much. You got that, John?
Got it.
Take a picture there.
Ready?
And that's looking like
That's
a pretty
not
good
bad.
view for us, Mark. It's a tiny bit high, I would say, but I think
We'll move it as we deploy.
we'll move it as we
Yeah,
deploy
it looks pretty good to me, I must say.
Okay, good. All right. So, Raghu, 180, pacing on, please. 180, pacing. Let that pressure come right down, John.
Just move that valve down a little bit.
Just don't do anything.
I'm
Don't
not
do
doing
anything.
anything. No.
Don't inflate. Okay, John.
Slowly, that's
Inflate
good.
now.
Slowly,
Up you go. Yeah, it's okay. Up you go, John. There you go. That is perfect. And balloon down. And pacing off. Thank you. Let me just...
There's our 3D acquisition done. Now we're going to immediately go back to 2D imaging. just to check that the valve's okay, which we can see it looks like it's in a pretty good position now. Just try a bit of colour flow on there. And this is looking good. We have a trivial amount of transvalvular aortic regurgitation, which is not surprising because there's still a catheter across it. And what we're going to do is just do some X-plane imaging across the valve, just at the level of the LV outflow tract.
The wire's biased across to the right, Mark, so you may be getting some leaflet capture, but we're comfortably under the coronaries.
Yeah, it's looking very good. Like, so far I haven't picked up any paravalve regurgitation at all. We'll just advance this now into the LV outflow tract, just beneath the valve. Remember, we still have a wire across the valve. This looks like a really good result because there's...
Let's not move until we know. So, Mark, we need an evaluation. Any AR? Are you
No,
happy
I
with that
can't see
position?
any AR at all.
Are you happy to take the wire out?
Yes, yeah.
It's caught in a cord, isn't it? Yeah. There we go. Lovely.
There we can see all three leaflets working nicely in there. We can see the left main coronary artery with flow in it and no valve regurgitation whatsoever, either transvalvular or paravalvular.
Follow us down. Just so I can see it's coming very easily. Actually.
Let's go back to a long axis
Leave it there, John.
view. Look at this.
This is going to just bleed when this comes out, so just so I don't make a mess. I'll have the introducer back, please.
We have the same level of mitral regurgitation as before. What appears to be a very good result. So we're going to go and try look at the transgastric views now, just to check on LV function, make sure there isn't a pericardial effusion. Just check the MR in this view on the way out. That is unchanged. And again, I cannot pick up any AR whatsoever. So now we advance the probe into the transgastric position. And there's good LV function. No obvious pericardial effusion. We will see if we can get flow across the valve from here, which may be a little bit difficult because it's such a small ventricle, but we're going to give it a try. And now we have Doppler flow across the valve from a transgastric view, which you can see here, with a maximum velocity of about 1.6 meters per second. And no detectable aortic regurgitation on there. So this looks like a really good result. Now, of course, we have to check and make sure there's no pericardial effusion. Just taking the probe out of the stomach into the mid-esophageal view. And we can see that this sapien valve is really in a almost perfect position now. It's covering the native valve leaflets very nicely. You can see the LV side of it is positioned precisely at the base of the anterior mitral valve leaflet, and the top of the sapien valve extends up and covers the native valve leaflets. And there are the valve leaflets very, very nicely coapting in the center there and moving. And as I said, if we turn colour flow on, there is really no discernible aortic regurgitation at all. So So we're just going to do a 3D zoom analysis of the mitral valve now. We can see here. Okay. And then we'll just do a 3D zoom data set of the sapien valve for completeness. Which you can see here. And then we'll recheck again the descending aorta on the way out. This has already been done though on the pre-procedure transesophageal echo, and it's important to say that this patient's had a complete transesophageal echo done prior to this procedure as part of her workup for the Tavi. So we just look at the descending aorta. Which does contain some atheroma, as you can see. So it's a fairly atheromatous aorta with a catheter still in it. Okay, Raj, can I take the probe out now? So I always ask our anaesthetist to take out the probe because we want to make sure that we don't disturb the airway on the way out.
So there's an unobstructed way out to the aortic root and valve itself. And what do we mean by the aortic root? Well, the aortic root really extends from the sinutubular junction, which I'm pointing out here. There's a faint ridge just at the top of each of the sinuses. It would include each of the sinuses, the left, the right, and the non-coronary sinus within the aortic root, and then would include the leaflet tissue, really to the basal attachment of the leaflets. And you can see the leaflets extend into the ventricle, and we'll come on to describe that. I'll describe that in a bit more detail in a minute. So the aortic root extends from the sinutubular junction then to the basal attachment of the leaflets. And in order to get a normally functioning aortic valve, all of the components, or the component parts, have to be formed and working correctly to get a normal aortic valve or complex. Let's look a little bit more detail about the support of the valve itself. You can see that there is heterogeneous support of the aortic valve, so it's partly muscular, and in the region beneath the left and the right coronary aortic sinuses, it's supported by septal muscle. But then that gives way to a region of fibrous continuity between the anterior leaflet of the mitral valve and the aortic valve itself. So the region of fibrous continuity, as you can see, extends mainly beneath the non-coronary leaflet. And usually at the ends of that fibrous continuity, there are thickenings, which we call the fibrous trigones. And the right fibrous trigone will be closer to the ventricular septum. And then in between those two regions that I've described to you already, we've got a crucial structure which I'm going to transilluminate from the right side of the heart to illustrate to you that it's the thinnest portion of the ventricular septum. It's the membranous septum, and that sits at the base of the triangle of tissue between the right and the non-coronary leaflets. So there you can see the light shining from the right side, sitting at the base. That's an important structure because it marks the position of the conduction axis. So we'd expect the left bundle branch to emerge at the junction of the membranous septum and the mitral valve at this point here. So in the normal situation then, the valve tissue is at some distance from the left bundle branch, but that will change when we get a stenotic aortic valve. The final thing I want to illustrate to you with a normal aortic root is the attachment of the leaflets. And in this heart, we've actually removed the leaflets to show how they are attached and how they begin at the sinutubular junction, you see here, and then run into the ventricle and then back up to the sinutubular junction. And so this gives rise to triangles of tissue, we call them interleaflet triangles, which are between each of the leaflets. And in fact, it's these triangles of tissue which form the distal extent of the left ventricular outflow tract. And they're formed at their top by the arterial wall of the aortic root. And it's important to recognize that because, in fact, if you perforate those triangles, if you're performing a balloon valvoplasty or surgery and you perforate those triangles, you will go outside of the heart. You'll be outside the left ventricle. What I'm showing you here is the interleaflet triangle towards the left side. So this is the left part of the transverse sinus, is the left mainstem coronary artery. And if I put a needle through the apex of that triangle from outside the heart, you see we're still beneath the level of the aortic valve. We're still within the left ventricle. So they form the distal extent of the outflow tract. There's 3 of these triangles, and perforating those, as I say, will lead outside of the heart into pericardial space. So this is the overall representation of the aortic valve in the normal heart. We have got rings or annuluses, if you like. The most obvious one, of course, is the ventricular arterial junction between the wall of the aorta and the ventricular mass. Sinutubular junction is often quite easy to recognize. That's at the top of the sinuses. And then the leaflet tissue will extend from the sinutubular junction into the ventricle and cross the ventricular arterial junction. But we can also draw a line around the base of the leaflets, which will be a virtual ring. And in fact, this is the ring that's often measured on echo. It's not a, as I say, it's a virtual ring along the base of the leaflets. And this overall structure then gives rise to these triangles of tissue between the leaflets and also to a slightly heterogeneous structure of each of the sinuses, because the base of the sinuses, because it extends onto the muscle, will be muscular in this region towards the septum and fibrous in this region towards the mitral valve. So the aortic valve in general then is a relatively complex structure. Important to remember the relationship to the conduction tissue, that it's partly muscular and partly fibrous, and that the hemodynamic junction is semilunar rather than a true annulus. So let's have a look at what happens in the setting of stenosis, to the anatomy in the setting of a stenosis. If you remember, in the normal valve, we had triangles of tissue between each of the leaflets which run the full height of the sinus, so up to the sinutubular junction. And that's because of the attachment of the leaflets. The paradox is that when you get stenosis, the leaflets become attached in a much more annular fashion. In fact, they're attached really along the line of the ventricular arterial junction. And often you'll see the fold or the raphe within the sinus at the point of fusion of the 2 leaflets. And then beneath that, corresponding to that, we have the reduced height of the interleaflet triangle. Usually, and I put this in just out of interest, the triangle above the mitral valve, so directly above the anterior leaflet of the mitral valve, is better formed. And that may be relevant to the location of paravalvular leaks in certain circumstances. But the point is that the valve is attached in a near ring-like fashion in the setting of stenosis. So I suppose it's more true to call it an annulus in this setting, even though in the normal heart it is not arranged in that way. So let me show you some examples. This one probably is a good candidate for a Tavi valve. So you can see there's fusion here between these two leaflets, and there's also fusion here between the right and the non-coronary leaflet, with quite a marked raphe there. The right coronary artery, in fact, is just sitting above the sinus, above the sinutubular junction. So that would be okay. And then here you can see there's quite marked calcification at this junction here. But the interleaflet triangles in all of the regions, in all of the, between all of the leaflets, are reduced in size. And we've got a more annular attachment of the leaflets at the junction. If I just show you that in another heart with stenosis, but which we've sectioned across, it will show you the relationship now of the valve to the conduction tissue. You see there's fusion between the leaflets, and here between the right and the non-coronary leaflet in particular, there's almost complete fusion between the leaflets and a very small interleaflet triangle just here. And of course the annular attachment of the leaflets now will bring them closer to the membranous septum and therefore closer to the conduction axis in stenosis. And the surgeons are aware of this, and I think it's probably an important thing to be aware of when you're performing a TAVI procedure. So here you can see we've cut across the membranous septum here, so this is right ventricle, tricuspid valve on this side, and the left bundle branch will emerge just at the base of that membranous septum, and you can see that it's much closer here to the valvar tissue in the stenotic valve. Some other examples of stenotic valves. This is quite a trifoliate aortic valve stenosis. There's calcification of the leaflets and also the sinuses, but the calcification really is only of the leading edge of the leaflets, if you like, only of half of the leaflets. The base here is really normal and quite mobile. So I think these leaflets could still fall back into the sinuses, be pushed back by the TAVI quite adequately. And there you can see the calcification extending around the right coronary artery. So this probably is quite a good candidate then for a TAVI procedure, except again that it's got a replacement mitral valve. This one is a ball and cage mitral valve, which is very well endothelialized. It's hard to see the sewing ring in this instance. This heart, I think, might be a bit more of a problem. You'll appreciate, as we view the valve from above, it really is a bicuspid valve with a oval shape or slit-like orifice. Now, there's quite heavy calcification in this example of the leaflets. Notice it's on the arterial side of the leaflets, and it extends really into the base of each of the leaflets, so they're quite rigid and they don't fall back into the sinus as much as they should do. You can see the annular attachment of the valve, very small interleaflet triangle here and just here. So the question is, should we be putting transcatheter valves in this sort of stenotic valve? Just to illustrate what happens if you try to put a circular valve in this oval-shaped junction, and this is just a simulation, of course, but you can appreciate that you can end up with triangles of space between the circular valve and, the circular transcatheter valve, the cage, and the valve tissue. So these can be the region of paravalvular leaks on either side, and it's the main reason, I suppose, where we don't, that putting them in bicuspid valve is contraindicated. Now this one is probably in between the two. There is fusion, complete fusion between two of the leaflets there, but I think this is probably a functional bicuspid valve, and it may be possible to split this commissure There is some calcification just here. But the main reason I'm showing this to you is to look at the coronary placement. And if you look at the right coronary artery, first of all, you can see that it's away from the leaflet tissue. The leaflet tissue is quite rigid, and I think if it was pushed back, it would be away from the right coronary artery. But if we look then, turn our attention to the left coronary artery, just here, you can see it's much closer to the valvular tissue, and in fact, there's a calcific nodule there that just wants to fall into the origin of the left coronary artery there. So knowing the coronary origins, I think, is crucial. And in the same heart, in fact, what we've done is put again the cage of the Tavi valve, the Edwards Tavi valve, in to confirm the fact that the right coronary is okay, the leaflet tissue is not obstructing the coronary orifice, but as we move towards the left side, just here, you can see that the cage is now pushing that leaflet and that calcific nodule into, or very close to, the left coronary artery origin. And then the final example, which is a big heart with a very thick wall and a dilated left ventricle, shows a peculiarity of the upper portion of the septum. Again, the valve is thickened and fused, but there you can see fusion between the right and the non-coronary leaflets there, and also between the right and the left coronary leaflets. So it's clearly a stenotic valve, but just turn your attention to this recess here beneath the right coronary leaflet. It's really quite a deep recess, and that's a result of the septum bulging out over and beneath the right coronary leaflet. And the importance of that, which Bushra will emphasize at the end, is that it can displace a Tavi, a transcatheter valve. So you can see here that you need to be aware of the presence of the septal bulge and its relationship to the underside of the cage.